everyone. Welcome to the IPNA endorsed Webmaster Series 2021. This is confined only to Pediatric Glomerular Disease Symposium, and we have entered into webinar 8. The highlight of the session is we have a lot of polling sessions. We have already done with 4 polling sessions, and today we don't have the polling sessions, but questions pertinent to this topic, we'll be having it in the subsequent sessions for the polls. And so today we have 3 eminent speakers. The first speaker is Dr. Meenaka Yadav. Dr. Meenaka Yadav was qualified DM pediatric nephrologist from All India Institute of Medical Sciences, New Delhi, and she is currently assistant professor at Lady Handridge Medical College and associated with Kalavati Saran Children's Hospital, Delhi. And her area of interest is towards acute kidney injury and critical care nephrology. She has also received Best Oral Abstract Award by IPNA in the year 2016, which was held at Brazil. And she has also received a Best Oral Award by Indian Society of Pediatric Nephrology in the year 2020. Over to Dr. Meenaka Yadav to deliver a talk on immune-mediated glomerular injury in children.
Hello, are my slides visible, ma'am?
Yeah, your slides are visible.
So I'll just switch off my video so that there is no internet problem and person.
Okay, fine.
So at the outset, I would like to thank the organizer, especially Dr. Kalaivani, to invite me to speak at this esteemed forum. And today, over the next 20 minutes or so, I will be speaking about the immune-mediated glomerular injury in children. And we'll go over the basics for the same and look at the various pathways and the way the glomerular injury may manifest. So just to get an idea for the same, we need to understand the glomerular components which are at the risk of injury and how do they manifest on encountering the stimulus or the injury. And the immunity, which again, as we all of us know, can be a component of innate as well as adaptive immunity. And finally, we'll have a brief idea about the leukocytes and the extracellular traps. I'll just enlarge the slides. Okay, so in the glomerular membrane components, as we can see over here, my pointer won't be seen, ma'am, right? Okay, so in this figure, we can see over here that the chief glomerular components comprises of the glomerular basement membrane, which in effect is the chief filtration barrier against the filtration of the proteins like albumin, and it also comprises of the mesangial matrix and the mesangial cells, which are the core or the axis of the glomerulus and act as a supporting stroma, and the endothelial cells, which in glomerulus are special in a way because of the fenestrated nature, the expression of various major histocompatibility antigens, and the only intrinsic cell in a way which are directly exposed to the circulating leukocytes or the bone marrow derived inflammatory cells. And then we know the podocytes, which is almost everyone's favorite in a way, and the parietal epithelial cells. If we zoom a bit and look more closely to the same, we can see the healthy glomerular basement membrane over here, the trilaminar appearance. On the outer surface, we can see the beautiful food processes of the podocytes in the healthy way. And if we can identify the endothelium over here by the fenestrated look as well as by the luminal platelets. So just like any newborns essentially manifest by any injury just by being lethargic or maybe just poor feeding or by excessive crying. Similarly, essentially all various forms of glomerular injury manifest by something getting deposited over there in the form of glomerular deposition or the immune complexes getting deposited. There is hypercellularity, which can be in effect because of the cellular proliferation or simply because a lot of cells come and get accumulated into the glomerulus. Or it can be due to it can manifest in the form of cell death or the capillary destruction. So these are the chief ways in which essentially a glomerular injury morphologically manifests like. And if we look more into that by the form of how an individual cell response is elicited and manifests in the form of clinical responses, that the glomerular basement membrane essentially when stimulated by an inciting agent leads to membrane injury, can lead to laminated appearance or membranolysis. And since it is the chief barrier against the to protect against the proteinuria. The injury manifests in the form of proteinuria or clinical edema. As we can see over here in this spike appearance in the membranous glomerular nephritis, in which proteinuria or edema or severe hypoalbuminemia is the hallmark. Again, if we look at the mesangial cells, it basically manifests because it is essentially the only cell apart from the endothelium. If we see in the previous figure over here, this is the one which is in direct continuity with the endothelium. At places there is no intervening glomerular basement membrane. So apart from endothelium, the mesangium is the one which is also exposed to the circulating leukocytes. And in effect, there is a mesangial fluid pathway through which various chemokines and the inflammatory cells may exert their effect. So again, the mesangial cell injury can manifest in the form of something getting deposited, as we just discussed, or there may be mesangial cell proliferation, which is seen in essentially almost all proliferative glomerular nephritis in a way, and almost the earliest one to be seen like in lupus nephritis. Or there may be increased mesangial matrix production, or there may be mesangial cell death. Usually the mesangial matrix proliferation and mesangial cell proliferation are the forerunner of sclerosis, which eventually can lead to the glomerular sclerosis and proteinuria, while the mesangial proliferation in effect is or the deposition manifests more in the form of proliferative picture. So this is basically, as we can see over here, there are clearly more than 3 mesangial cell nuclei over here, and this is how the increased mesangial cell proliferation looks like when we examine histologically. The endothelial injury manifests again in the form of cell proliferation, but apart from that, fibrin deposition is one of the characteristic hallmark of the endothelial injury. And double contouring of the capillary basement membrane is one of the hallmarks of the chronic endothelium injury, like we see in chronic thrombotic microangiopathy or in the antibody mediated rejection in transplant. So this is basically glomerulus, which is essentially having a very full appearance. If we see, we can't actually say that there are hardly any open capillary loops, which is when we say that there is endothelial hypercellularity, which can be due to endothelial cell proliferation, or it can simply be due to increased inflammatory cells arriving and staying for a longer time in the capillary lumen. Podocytes, as we know, it manifests mainly in the form of food process effacement, leading to eventual proteinuria because of the loss of the integrity of the slit diaphragm and leading to more proteinuria, but it also has contribution along with the parietal epithelium to lead to the crescent formation. Again, this there is some issue. Okay, I'll go to so. This basically shows that there is food process effacement in this slide. Broadly, if we classify these immune responses, we can classify them as leading to inflammatory injury versus the non-inflammatory injury. And to simplify the same, we can see, as we just discussed, the endothelium and mesangium are the ones which are exposed to the circulating cells, and they basically manifest the injury by form of infiltration and the proliferation. These are the pictures when we look at the inflammatory pathology or the inflammatory injury to the glomerulus, like we see in proliferative glomerular nephritis or lupus nephritis, and it manifests in the form of cell proliferation, infiltration, thrombosis, necrosis, and crescents. So clinically, these patients will manifest with the active urinary sediment or the proteinuria or the reduced GFR, or that means they will come with the deranged creatinine or the microscopic hematuria as well as proteinuria. While the non-inflammatory one is usually which targets the podocytes, is associated with subepithelial deposits that is a bit far from the circulating leukocytes, and they tend to manifest with no or minimal hematuria, with essentially proteinuria being the cardinal manifestation. The characteristic example, as I just discussed, are Ig nephropathy, lupus nephritis, and infection-related GN in the inflammatory pathology. Now, infection-related GN, one can argue that it is more of a subepithelial humps, but still it is associated with more of an inflammatory and overtly inflamed-looking glomerulus, which is chiefly seen because the hypothesis is like maybe the injury actually starts with the subendothelial, but we tend to pick it or look at more of when the injury is more towards the subepithelial hump pathology. The non-inflammatory ones are the obvious minimal change disease and membranous nephropathy, in which there is hematuria is very rare or to the minimal degree only, but there is significant proteinuria and edema. Again, the same picture which we just discussed, and we can see over here that towards the capillary aspect, that is the endothelial aspect of the GBM, we have the dense deposits, which we call as the, which will classify for the subendothelial deposits, while the food process look apparently fine. In the later we can see that it is more of the spikes and crater appearance of the membranous nephropathy, which in EM will look like the electron dense deposit, which are towards the food process side, that is towards the podocyte aspect, leading to that's why they are called as subepithelial deposits. And over here we can see that food processes also look a bit on the effaced aspect, so patient is more likely to have proteinuria in this case. So essentially, as we just discussed, somebody is born with a few things which is more of a survival instinct and is more specific, and rest we acquire over the time. And same goes for the immunity. So we have an innate immunity, which is more of something which comes into picture very early enough, is more non-specific, and then a more matured in a way and more adaptive and specific with the memory, which constitutes the, and in together they lead to the total component of the immune response to any antigen. This figure, as we can see over here, again highlights the same point, that both innate immunity, which is being shown over here in the orange and the orange color, and the blue aspect shows the adaptive immunity. So whenever there is an etiological event, which can be in the form of pathogen-associated molecular patterns or the damage-associated molecular patterns, these patterns are basically identified by the toll-like receptors, which or by the complement system, with eventual stimulation of the circulating inflammatory cells, as well as the stimulation of the resident glomerular cells to lead to more oxidant injury and the chemokine production. While there is a concomitant presentation of these antigens to the CD4 T cells, which then decides the adaptive immune response in the form of the Th2, Th1 or Th2 and Th17, as we'll see subsequently by the various cytokines, or the production of the B cells and the antibody-mediated injury. So coming to the first aspect as antibody mediated, because it is usually the principal cause of injury seen in glomerular disorders. It is chiefly immune complex driven, but again, as you'll see, it can be antibody driven rather than just immune complex driven. It can be against the intrinsic antigens, like we know as the non-collagenous domain of the collagen 4 in the glomerular basement membrane, and again it can be against the like the PLAR2 antigen in the membranous nephropathy, while it can be against the planted antigens as well, which like the tumor antigens or maybe nucleosomes which come and get deposited over there, or there may be extrinsic antigens like the various infectious agents like streptococcal or maybe syphilis or viral hepatitis viruses, and they can then subsequently either in situ or subsequently they can get trapped inside the glomerulus. So this essentially shows us division of the figure which we just saw. It leads to the stimulation of antigen presenting cells, and subsequently the arm which leads to the B cell stimulation, leads to the production of autoantibody and immune complexes. If we see in the figure A over here, this is basically which happens in most of the circumstances when antigen is in surplus amount or is on the higher amount than the antibody. Then there tends to be more of circulating immune complex formation, and there is a tendency towards larger lattice formation, which gets deposited to the chiefly to the subendothelial and the mesangial location. While when there is in situ immune complex deposition, it is basically when the antigen gets distributed on its depending on its size or charge, the smaller ones may traverse to the subepithelial aspects, while the larger may get retained at the initial aspect itself, or maybe the cationic one will be able to cross. So by that charge and the molecular size, the antigens get planted, and subsequently the circulating antibodies come and bind to those locations. Again, as we just discussed, there can be antibody formation to the intrinsic antigen. Like in this, we can see the GBM having the intrinsic antigen in the form of non-collagenous domain of collagen 4, or there can NC terminal of collagen 4, or there can be annexin in the mesangial cells, or there can be endothelial antigen which incites the antibody formation and leading to in situ immune complex deposition. So immune complex depositions are basically can be determined by the various properties like the charge of the reactant as well as the size of the circulating complexes. So the highly cationic ones, they tend to go more towards the subepithelial aspects after crossing the GBM, while anionic ones, they tend to get retained and lead to subendothelial and inflammatory pathology, while mesangial is more of a political and neutral nature. The larger ones, they tend to be either not nephritogenic or they tend to be on the subendothelial aspect, or they tend to not lead to any pathology, while the smaller ones, if they get retained or immune complexes, they get deposited on the endothelial side, they tend to be nephritogenic, while if the individual antigen is relatively small rather than the complexes, they tend to cross to the podocyte aspect. The clinical consequences of immune complexes deposition varies, and that is basically determined by what are the intrinsic properties of that antigen and antibody. Like the IgG1 and IgG3 are the most which lead to more of inflammatory pathology and more inflammation. Similarly, in C2 deposition can lead to more proliferative injury rather than the passive immune complex deposition. Logically, increased quantity will lead to more inflammatory pathology. And again, as discussed, subendothelial and mesangials lead to more of inflammatory pathology compared to the subepithelial aspect. So this basically manifests in the form of whether the disease will be associated with more of inflammatory pathology or the active urinary sediment or more of proliferative glomerular nephritis versus the non-inflammatory one. And again, the presence of antigen at the distant location can lead to more extensive pathology or the systemic manifestations as well. Now, B-cell immunity or the antibody-mediated immunity does have other weapons as well, and the immune complexes itself may be damaging, which is characteristically exemplified by the underglycosylated IgA1, which have altered properties in the form of they have a tendency to self-aggregate. Besides this, they can lead to, by itself can lead to activation of mannose binding lectin, or by the alternate pathway activation by inciting the IgG antibody formation against them and through the immune complex deposition. So increasingly it is seen that that complement has got a very important role to play even in IgA nephropathy. Again, in the anti-GBM, because of this antibody immune complex formation and the alternate pathway activation, as we'll see subsequently. Even in anti-GBM antibody formation, there is significant epitope intramolecular and subsequent epitope spreading, which leads to the ongoing injury with the anti-GBM membrane disease. So coming to the second arm of the adaptive immunity, which is the cell-mediated injury. And in effect, if we have to classify the role of T cells, it is there in almost the entire arm of adaptive immunity. But if we go strictly by what they do as individually, then it is a relatively more limited one rather than just being a helper to the B cells. So they serve to help the B cells, but they are also involved in the antibody-independent tissue injury, which can be through the various TH subtypes like TH1, TH2, which is more so in the non-inflammatory or the nephrotic syndrome or the nephrotic syndrome pathology, while TH17 are increasingly being identified as relatively the more damaging one associated with direct tissue injury as well as by recruitment of the more of neutrophils and the inflammatory cells to the site of pathology. T regulatory cells are the one which are more of the monitor ones in a way that they tend to regulate or induce more of immune tolerance to the ongoing event. So if we see over here on inciting, on getting a stimulus through any circulating pathogen or the antigen and receiving a co-stimulatory signal, it leads to the antigen specific to CD4 specific subsets are generated, which can be TH1, TH2, and then TH17 based on the specific interleukin, which leads to the specific subset generation. And then subsequently, By releasing specific cytokines like Th17 through interleukin 22, it can lead to direct tissue injury, while interleukin 17 and 21 would lead to more of subsequent recruitment of inflammatory cells. Th2 is associated with more of IgE and eosinophil mediated injury, while Th1 leads to interferon gamma and subsequent macrophage recruitment, like we see in crescentic G and in Possimmune, where macrophages are relatively more of the effector cells in a way, while the T regulatory cells are the one which down-regulate and lead to immune response and tolerance. The T regulatory cells are the ones which are being increasingly recognized, and interestingly, if we say by an example in the anti-GBM disease, these are the ones which they later on tend to increase, which in effect explains why there is less of a recurrence observed, or the relapses are relatively less with that disease. So again, T cells can manifest in the form of non-inflammatory injury, as we know in proteinuric diseases, while it can be as catastrophic as the severe inflammation or crescents in the ANCA-associated vasculitis and C3G anti-GBM disease, as we can see over here with the crescent formation, in which the T cells, specifically the CD8 cells and the macrophages, have an important role to play. Now, we have an entire talk today in today's session on the complements. So I'll just go briefly over this, but it is an important part of the innate immunity and the most complemented one complement. So I'll just go over it briefly. It is basically an ancient system protein, as we know, and kidneys are somehow uniquely susceptible to complement injury, as we'll see how. It reduces the risk of autoimmunity in a way like C1q has a role to clear up the mess after any inciting stimulus to avoid the damaged proteins or the nucleosomes to get on to trigger the autoimmunity. But again, it is, as we are well aware, it is the one which leads to the mediation of the tissue injury through autoantibodies as well. These are the three pathways, as we know: the alternative pathway, which involves C3 factor B and D, and the lectin pathway in the center, and the immune complex driven classical pathway. This all of them, they basically lead to the formation of C3 converters and C5 converters, which eventually lead to formation of C5b29, which leads to the membrane lysis and the other cells. But in the entire pathway, also the various products which are generated, like C3a, C5a, they also lead to the subsequent tissue injury and recruitment of the inflammatory cells to the pathology. The C3 or the alternate pathway is essentially the one which is more like the sleeper cells, which are more or less active but are not really seen. But when inciting on the stimulus, they tend to get rapidly get amplified and lead to the tissue injury. And if we go, this is basically for the example in a way. It is the classical one, as we know, is more involved in the lupus and initially in the immune complex mediated glomerular nephritis. But increasingly, there is more of an overlap. Like the infection-related one was initially we used to read in the classical, but now we see alternate pathway has an important role to play as well. And even in Ig nephropathy, as we just discussed, though lectin pathway is said to be important, the alternate pathway is involved as well. Atypical HUS and C3G, as we all are aware, is involved in the alternate complement pathway. Apart from the chief complement pathway, the complement regulatory proteins are also important, and they can be in the form of soluble complement regulatory protein, as we are aware, with the complement factor H and the other helper cells like complement factor I. And apart from that, there are surface bound complements as well, like the CD46 or the membrane cofactor protein. They are important in a way because they tend to regulate the ongoing complement activity, but they are also important to us because they lead to the formation of the markers through which we can identify that there is complement activation. So basically, when there is alternate pathway activation, it leads to the covalent binding of this C3b to the active tissue, while the classical one leads to the covalent binding of C4b fragment to the tissue. And this C3b, which is essentially a part of the alternate pathway C3 convertase, is stabilized by the properdin, and this leads to the further tissue injury through the C3 convertase pathway till the convertase is decayed or till the part the C3b gets inactivated by the factor I. Now, factor I also needs the presence of factor H and the other cofactors to lead to the degradation of C3b in the form of inactivated C3b and subsequently C3d. And this histologically, when we see the C4d is as a marker of the antibody-mediated injury, like in transplants, or C3c, which we pick in immunofluorescence in a case of, for example, C3g, essentially serve as a marker that there was a complement injury ongoing, because C3 in blood may not always be low in these cases. This is essentially known to all of us, as we used to read in microbiology, as the adaptive function in the form of pathogen killing and clearing up the injured cells, and the co-stimulation to immune cells and removing all the cellular debris to avoid autoimmunity. But the more we are usually, what we end up reading subsequently is, as a nephrologist, is that they promote the tissue inflammation and the direct injury to host cells. But again, we need to remember both the aspects, as exemplified by the eculizumab, which is associated with severe meningococcal infection. And it has been seen that even the use, despite the use of vaccination, nearly 1% they tend to develop severe Neisseria infection despite vaccination. So while using the complement agent, especially when we go more upstream into the complement pathway, we should always be aware of that it is in effect leading to the compromise of the adaptive function and secondarily reduced immunity as well. As we just over the time we were discussing that why it has to be glomerulus, why we as a nephrologist have to continue reading complements, why rest of all can stop over in the microbiology as well aspect itself. So basically the exact cause is unclear, but if we look at the morphological aspects and the way in the glomerular structure itself, the microenvironment ends up favoring the in concentration of the plasma protein and the complement fragments in the glomerulus. Apart from that, mesenchyme and the specialized endothelial cells, which are fenestrated and express the proteins, are more likely to attract and respond to any inciting stimulus in the circulation as well. Apart from that, it has also been seen that even the tubules may be involved by local production of the complement proteins, as well as probably a reduced expression of complement regulatory cells as well. So as expected, that kidneys predisposed to complement is involved in almost all glomerular diseases like lupus, Ig, and Cypriot nephropathy, and alternate pathway like I think we'll discuss subsequently also the fluid phase getting altered in the C3 glomerulopathy, and the surface binding surface activity of the factor H getting affected in the HUS disease. Complement again has got a role in progression of glomerular injury as well. So basically what happens is when there is ongoing glomerular injury, or when in healthy state there is less of the tubular interstitial damage due to complement. But when there are proteinuric state, when there is more of filtered complement protein, and in effect there is more inciting of the local production of complement in a setting of reduced complementary regulatory protein, it predisposes to the further progression of the glomerular disease, which is augmented by the increased ammonia genesis when the nephron mass is reduced, which leads to alternate pathway activation, and the vicious loop of the progressive inflammation and damage continues. Finally, coming to the leukocyte and the extracellular traps. So leukocytes, even though we are discussing relatively at the end, these are the ones which come up as the first cellular defense. But as a part of innate immunity itself, they don't have self-discrimination, don't have memory, and usually the stay in capillary lumina is less than a minute. But in the inflammatory pathology, they tend to stay over for a longer time, which predisposes them to release more of reactive oxygen radicals and proteases, and the injury to the glomerular structure through secondary halogenation as well. Apart from this, the interesting mechanism of injury seen with the leukocytes is the formation of extracellular traps.
So currently, the current presenter presenting their slides.
Okay.
So when your talk coming, you can present your slide.
Which leads to the formation of the, so basically extracellular traps are the one which are the chromatin which get extruded into the extracellular space. And in effect, because the extracellular chromatin has got the histones which get extruded extracellularly, they are essentially identified by the patrolling cells and the immune cells as a damage-associated molecular pattern, which incites further cell injury and the cytotoxic effects through these extracellular traps. So even though it was described as a pathogenic fixation and killing in 2004 or so, it has got the collateral tissue damage as well. So even the innocent one get killed by this trap, and the sterile tissue injury happens. And when there are extracellular traps which get cleared less effectively, it promotes autoimmunity, as we'll see subsequently has got a role in lupus nephritis as well. So this figure basically shows when there are patrolling neutrophils, when they encounter the inflammatory milieu in a organ injury. So say, for example, in a case of sepsis, ATN, or secondary to some inflammatory pathology, they tend to release their extracellular traps. And these histones, they go and damage the endothelial cells. And because of the endothelial injury, they gain access to the extracellular space, where they tend to lead to further organ injury and lead to the chemokine release, which leads to further recruitment of the neutrophils and the inflammatory cells to that pathology. That side. So apart from these, they can, in effect, by itself, these this extracellular histone can lead to the stimulation of the toll-like receptors and the innate immunity arm to lead to further damage and the glomerular nephritis. Apart from that, it has got role in the associated acute tubular necrosis as well. As we can see on the right hand side, the extracellular traps released by the neutrophils as well as macrophages, they lead to further tubular necrosis by release of cytokines through various immune cells. And they are increasingly implicated in the ANCA-associated vasculitis, in the lupus nephritis, and also in the other immune complex glomerular nephritis, and in the progression of post-ischemic and septic acute kidney injury as well. If we go over quickly to the other cellular mediators and the circulating one, the cellular mediators, as we discussed, is the neutrophils, and apart from that are the macrophages and the T lymphocytes and the platelets. So neutrophils, they get attracted to the inflammatory side by the anaphylate toxins or the FC-mediated recruitment of the neutrophils to the inflammatory site. And we just discussed, they can release various proteases, reactive oxygen species, and the traps to lead to the further augmentation of the inflammatory pathology. The adaptive immunity leads to the stimulation of macrophages, and macrophages are in fact the principal effector agents which are involved in the crescentic glomerular nephritis and the chronic progression of any glomerular nephritis over the time. Okay, there is some issue. Okay, and platelets, they when get stimulated, they release various growth factors which lead to further proliferation and vascular injury. I think there is some problem with this slide. So I'll switch over to the next one. The circulating mediators involve the complement proteins as well as nitric oxide, endothelin, and the apart from the complement products, the hemodynamic factors like endothelin, nitric oxide, and the cytokines and chemokines like the interleukin-1 and the TNF, and various growth factors, as we saw in the previous slide, by the platelets and the intrinsic glomerular cells. They basically lead to more of leukocyte attractant and to the amplification of injury, while the hemodynamic factors like endothelin can lead to further vascular injury. The chemokines, they end up attracting more inflammatory cells to the sites, and the growth factors lead to further augmentation of the cellular proliferation, extracellular matrix deposition, and lead to a procoagulant state in the kidney. All of these, as we just discussed, they act in effectively in combination. So it is all the innate immunity, the adaptive immunity, and the complements, they get stimulated, as we saw in the initial figure itself, they get stimulated side by side and most of the time at various places. And in effect, all of them in combination lead to the final damage or the glomerular injury which we see. And as usual, the best example for the same is lupus nephritis, which can almost fit in everywhere, like in every histology site as well. As we can see in this figure, the apoptotic cells is basically expressing the various apoptotic vesicles, which have the extra cell, which lead to the formation of the stimulation of the autoimmunity by formation of the autoreactive B lymphocytes, as well as the formation activation of the complement pathway, secondary to the reduced apoptotic material clearance because of the problem, because of the paucity of the function of C1q and the other roles of the complement pathway, and because of this immune complex itself can lead to complement activation, or it can lead to the secondary damage by inciting the plasmacyted dendritic cells and interferon gamma mediated damage leading to the lupus nephritis. Again, in the proteinuric state as well, as we can see over here, the innate adaptive arm itself may be involved upfront by the sensitization of the B cells and the plasma cells, leading to the antibody formation and the immune complex mediated classical subsequent damage through complement pathway, again forming the part of innate immunity when we discuss the complements and the toll-like receptor or the inflammatory cells. And in effect, all of this, they lead to the damage to the filtration barrier or the GBM and podocytes, which we just discussed, leads to the proteinuria or the non-inflammatory pathology, or it can be as severe as inflammation and crescents, chiefly when there is more of excessive inflammatory injury and the involvement of the parietal cells and the podocytes, which can lead to the active urinary sediment and the proliferative glomerular nephritis. The next slide is this is bit of a simplification, but if we have to classify in a way in a broader aspect by the various immune mechanism involved in the diseases, the lupus nephritis membranous are the ones, and even the transplant glomerulopathy secondary to chronic antibody mediated injury, while the nephrotic syndrome or the ANCA vasculitis are the chiefly cell mediated one. Again, there is the role of complement as well as we in the ANCA vasculitis as well. But while the pathway is more of a complex in the Ig nephropathy and in the progression of kidney diseases and the C3 glomerulopathy. So with this, I'll end up summarizing that the manifestation of the glomerular injury vary depending on the inciting stimulus and the nature of the inciting stimulus and the immunity arm triggered or the cell targeted. It can manifest in the form of inflammatory injury or the proliferative pathology, or the non-inflammatory or the relatively benign or the non-proliferative pathology or proteinuric injury. And the adaptive and innate arm both act and interact at the same time. And this pathogenesis serves as the markers to leave the trails or the markers to understand the disease better and lead to the further role for to understand the targets to treat these diseases. This figure is basically from one of the Jason article I just liked in the form of, because more or less we are usually focused on the podocytes these days. This was more for the mesangial cells, and it highlights how the mesangial cells are involved in increasing the available glomerular basement membrane area by their active contractile and the retractile nature of the mesangial cells. So even though it was historically much interested upon, nowadays it is less of the focus. With this, I'll end the talk. Thank you.
Thank you, Dr. Meenaka. It was an excellent talk, taking us through the glomerular injury in children's. And Namalva sir, do you have anything to add, sir? Namalva sir? So the next speaker is Dr. Sukanya Govindan. Dr. Sukanya Govindan is she has completed a DM nephrology from PGI Chandigarh and her FISN fellowship from Great Ormond Street Hospital for Children from UK. She is associated with Mehta Multi-Specialty Hospital, Chetpet, and the other branch Global Campus. And her area of interest is towards early detection of acute kidney injury in children and AKI therapeutics, low-cost renal replacement therapy in children, and vascular access and surveillance. Now I request Dr. Sukanya to deliver a talk on infectious and non-infectious complications of immunosuppressants in nephrology. Over to Dr. Sukanya.
I hope I'm audible. Thank you, Dr. Kalaivani, for that kind introduction. And I congratulate both you and Professor Namalva for putting together such a very organized and a focused Symposium on Pediatric Glomerular Disease. I also congratulate my fellow speakers today for their talks. And moving on to the talk. So this topic was complications of immunosuppressive therapy in nephrology. So it's quite a broad this thing, but for the use and for ease of presentation today, I'm going to broadly outline certain principles and what we do with complications, how we deal with them. So this is what we'll discuss today. I'll give you a brief overview of immunosuppressants and go into complications of therapy for each classes of these immunosuppressants, what screening and monitoring tools that we have currently, and if at all there are any strategies to reduce complications. So immunosuppression in nephrology is provided in various disease conditions. One of the most important conditions being the glomerular disease, and we saw that most of these glomerular disease have immune-mediated injury in their backbone, which was wonderfully elicited by Meenaka before. So glomerular disease form the major group where we use immunosuppression in nephrology. We might use it for nephrotic syndrome, glomerular nephritis, both of which could be primary or secondary causes, secondary glomerular nephritis. There are also various vasculitic syndromes which involve kidney, and sometimes even the nephrologist comes into the picture when there is non-renal involvement in vasculitis. So these are the major group of disorders where we use immunosuppression currently. There are also plenty of micro and macrovascular disease. The microvascular, the most important being hemolytic uremic syndrome and other thrombotic microangiopathies that one can see. Again, with vasculitis, there are mostly kidneys involved in the small and medium vessel vasculitis where we routinely use immunosuppression. There are a couple of other non-transplant conditions where we use immunosuppression. Predominantly, they could be acute interstitial nephritis, which are refractory to withdrawal of the inciting agent or steroids. And there are also a group of structural kidney abnormalities called ciliopathies, where time and again, now and then, immunosuppressants have been used. The other bulk of immunosuppression practice that comes in nephrology is in the organ transplant, both renal and multi-organ or non-renal transplants. So what are the principles of immunosuppressive therapy and how do we deliver them? And this is very important to understand how to understand the complications that come with these agents and also how to prevent them and when to look for them. So the immunosuppression is basically delivered in two phases in some of these disease conditions that I just outlined above. In a heightened form of immunosuppression, which is called induction therapy, is given at the start of therapy, wherein you block all the mediators that are responsible. And that is probably one of the highest immunosuppressive load that a child or an adult could have, followed by a maintenance immunosuppression regimen, which sort of maintains the effects that we have achieved by the induction agent and prevents relapses. So this two-phase therapy is usually given in conditions like lupus nephritis and also in certain autoimmune conditions, vasculitis, and majorly in transplant and when you're dealing with an acute rejection episode, where you sort of give an induction agent or an anti-rejection therapy and heighten the maintenance immunosuppression. In predominantly other than these conditions, we use either steroids or other immunosuppressions, either as monotherapy or in combination. We use 2 or 3 immunosuppressive agents or immunomodulators. But ultimately, the balance of immunosuppressive therapy in your mind is always between the kidney survival or the kidney health and balancing the drug toxicity so that you maximize kidney survival, you maximize patient survival, but at the same time, you decrease the toxic effects of these drugs. We do this by doing risk stratification of both the patient and drug profile, any duration of therapy, and also the dosages of therapy. Moving on to specific implications in children. On the overall, the therapy, the immunosuppressive load for the above diseases that I said is going to be higher in terms of transplant because it's a cumulative immunosuppression that is given to a child or an adult over a lifetime. So for a child, the lifetime risk of immunosuppression is highest in transplant compared to an adult because they live a number of years on these immunosuppressive agents. The second highest load would come probably in conditions with autoimmunity, where the immunosuppressive autoimmune diseases, proliferative glomerular diseases, where we use very potent immunosuppressive agents to induce remission in the kidney, followed by the lowest probable immunosuppression load is seen in primary glomerular disease. The unique aspects in children are that these children receive these immunosuppressive agents at a very younger age. In terms of transplant, for live donor transplant and also in deceased donor transplant, they sort of receive a donor from an older person who are not immunologically or infection naive. They also end up receiving multiple agents throughout life, either as in view of their primary disease condition or in view of transplant. Children are immunologically naive. They have lesser infection exposure, which puts them at a risk of multiple infectious complications later in life. They have an increased cumulative exposure of these immunosuppressants because their lifetime risk is very high compared to adults. They also have unique needs and specific concerns with regards to growth and development, the very turbulent adolescent period, and also many of these therapies can interfere with reproductive health in the future. Many of them, because they start receiving these drugs at a very young age, even after the primary disease has been controlled and the immunosuppressants have been stopped, many of them do go on to have secondary effects because of these immunosuppressants, which can last for life. So moving on, so I would like to broadly classify the immunosuppressive agents into the following categories so that it's easy later to discuss the complications and how these drugs act. So I put these immunosuppressant, all the available medications into the following groups: the T-cell targeted therapy, B-cell therapies, complement targeted therapies, pooled polyclonal antibodies or otherwise called depleting agents, anti-proliferative agents, and also antimetabolites and cytotoxic agents. So the T-cell targeted therapies are aimed at any one of these signals. We all know that alloimmune response or immune response starts with the T cells of the identification of an antigen by the T cell receptor. The T cell receptor samples these antigens and puts them into a self or a non-self antigen. And then if it's a non-self antigen, there is T cell activation. So the first step is the presenting of the antigen by the antigen presenting cells to the T cell receptor, followed by which, if in the presence of a non-self antigen, you have the stimulation of the T cells, which happens through a step called co-stimulation. And then further, if the co-stimulation is successful in activating the T cell, you have downstream activation and proliferation, which is majorly mediated through a number of cytokines. Moving on, so what are these T cell targeting agents? You have, very early on, we had this anti-CD3 monoclonal antibody called the muromonab. All the T cells express a marker called the CD3, which is very essential for the action of the APC, interaction of the APC with the T cell receptor. So inhibiting the CD3 sort of blocks completely the activation and further proliferation of T cells. These agents are extremely toxic and have, and over the years have lost completely their use in nephrology or in any other field in medicine. The second step is the calcineurin inhibitors. The calcineurin forms an important part in the early activation of the T cell once the T cell stimulation has happened. So the calcineurin molecule actually dephosphorylates the NF80, which is a nuclear factor of activated T cells. Once it is dephosphorylated, the dephosphorylated form can easily translocate into the nucleus, further on producing multiple cytokines, of which the most important is probably the interleukin-2. So the calcineurin inhibitors are probably come in the very first or the second step. They are early T cell activators, and calcineurin inhibitors can block this step. There is also a non-immunological action of calcineurin inhibitors that helps us in treating, that is beneficial in treating children with glomerular diseases, which is stabilizing of the actin cytoskeleton. So we use it predominantly in proteinuric states to achieve remission. The second step is the co-stimulatory blockade. So the co-stimulatory molecules are something that is also expressed on the T cells and have a corresponding ligand on the antigen-presenting cells. So one of the important molecules being the CD80 and 86, which are otherwise called the B71 and 72, and also the CD40 ligand, which has a corresponding CD40 epitope on the APC. So moving on. we have these calcineurin inhibitors. There are currently 3 available calcineurin inhibitors in the market. The last one, voclosporin, is not yet widely available. It's predominantly being studied in adults, and pediatric data is yet to be released. You have cyclosporin A and tacrolimus, which are currently the most commonly used calcineurin inhibitors. These drugs are not without their toxicities, although these are one of the most widely used T-cell targeting agents, both in glomerular diseases, autoimmune conditions, and also are currently still the primary T-cell agents for renal transplant. They have a multitude of side effects. As pediatric nephrologists, we still considerably use cyclosporin in our practice because in younger children, it's one of the easiest formulations to give them. Both cyclosporin and tacrolimus have equal nephrotoxicity and also have some tubular disorders which can manifest as metabolic acidosis and hypercalciuria and hypomagnesemia. There is no difference in the nephrotoxicity or in the tubular disturbances, but tacrolimus sort of slightly fares well in these conditions because tacrolimus is a potent immunosuppressant as a lesser dose compared to cyclosporin. So in view of the lesser doses of tacrolimus that could be used in these conditions, the nephrotoxicity and other metabolic effects that we see with tacrolimus are comparatively less when compared to cyclosporin. Cyclosporin has some effects which are slightly more than tacrolimus in terms of hypertension, dyslipidemia, and hyperuricemia. But however, tacrolimus has a considerable effect on the pancreatic islet cells, which produces hyperglycemia, and this is more especially seen in the context of pediatric transplant in the form of post-transplant diabetes mellitus. There are also multitude of cosmetic side effects, especially seen with cyclosporin. Moving on, you have the co-stimulatory So the co-stimulatory blockade. So of the co-stimulatory blockade agents that are currently in use, probably the most well accepted and the most studied is B-latacept. These are I spoke about the CD80 and the CD86 molecules on the APC. There is also another molecule called the CTLA4, which suppresses the co-stimulation, and the B-latacept is an fusion protein of immunoglobulin combined with the LA4 protein, which finally blocks this co-stimulatory pathway. So B-latacept is currently used as a substitute for CNIs in renal transplant. There are very few studies which are available in children. The case reports are available. So the B-latacept is delivered as an IV infusion, and the huge advantage of these over calcineurin inhibitors are the relative nephroprotection that these and the long-term graft function that these agents offer. But these are again not without their side effects due to the widespread blocking of the co-stimulation on the lymphocytes. These agents give a higher risk of post-transplant lymphoproliferative disorders and also progressive multifocal leukoencephalopathy. So moving on, agents that act on signal 3, which I said are responsible for the later stages of T-cell differentiation and proliferation. So these are mainly mediated by plenty of cytokines, and cytokine inhibition is being used for a long time in nephrology, and there are agents that act broad spectrum on a multitude of cytokine profile, and there are also agents which act on specific cytokine markers. So the broad spectrum cytokine inhibitory agents are the corticosteroids and the Janus kinase inhibitors. Current use in nephrology is limited to corticosteroids. Janus kinase inhibitors have a huge infection load, and they are currently approved for use in rheumatoid arthritis. I don't think we would be seeing this drug used in nephrology anytime soon. So corticosteroids and also Janus kinase inhibitors provide broad spectrum cytokine inhibition because they act on transcription factors like the NFKB and the JAK-STAT pathway. So these pathways are inherently useful or inherently necessary for further cytokine storm creation or further cytokine actions. So that's how they provide such broad spectrum actions. Coming to specific cytokine inhibition in nephrology context, the most important one is the interleukin-2 receptor antagonist, which is either which is the basiliximab or the daclizumab. Daclizumab is no longer available. So basiliximab is the most commonly used interleukin-2 antagonist in renal transplant, and especially in children. So moving on to the side effects or the effects, that unwanted side effects of these drugs, corticosteroids, as they have a huge spectrum of action. They also have a broad range of side effects, not only to infections, but also metabolic side effects. Inhibitors, they inhibit growth to a great extent. They also have actions on skin, eyes, GI tract, and also hematological complications. And these complications are also shared by genus kinase inhibitors too. Importance is the dosing of corticosteroids, at which doses do these complications occur. So this is one of the longitudinal studies in rheumatoid arthritis that was conducted in children over many years of follow-up, and probably one of the best studies that is available. This study is also important to notice that even when you give low doses of corticosteroids over a prolonged course of time, they do have a considerable side effect load or considerable adverse events. So even most of the pediatric patients who are on nicely in remission without any relapses of their nephrotic syndrome or autoimmune diseases, many of them go on to receive at least slightly lesser doses of steroids for a considerable amount of time. So receiving even these doses of steroids have shown to have an effect on survival-free, adverse event-free survival. The interleukin-2 receptor antagonist, on the other hand, has an excellent side effect profile. They are they definitely have much safety compared to the other induction agent that we use in transplant, which is the anti-thymocyte globulin. Except for a few transfusion reactions, these agents are pretty much safe. Moving on to the next group of drugs, which are B-cell targeted therapies. So the various B-cell targeted therapies are either direct B-cell inhibition, which are CD3 and CD22 monoclonal antibodies, agents that act on B-cell differentiation through factors like BAF and BLIS or TACI immunoglobulin fusion proteins like your belimumab or atacicept. There are plasma cell targets, which are bortezomib, and there are downstream complement inhibitors like eculizumab. About these agents, and especially the complement inhibitors, because we have a very excellent talk coming up on that. Your B-cell targets, which are anti-CD20, which is your rituximab, it is a chimeric protein, and that is the protein that is being widely used in nephrology practice. They are used in nephrotic syndrome, autoimmune disease, and also in the context of renal transplant, and sometimes in the treatment of post-transplant lymphoproliferative disorders. So these agents produce infusion reactions, which is more commonly seen in the initial few minutes of infusion. They can range from a mild reaction to very severe reaction, even resulting in death. So re-medication and monitoring is very essential. Most of these agents, as they act on B cells, activated B cells, they end up producing hypoglobulinemia, which in turn increases the infection risk. Majority of infections are either in terms of opportunistic infections and also reactivation of latent infections like tuberculosis, hepatitis B and C reactivation. A unique side effect to the chimeric monoclonal antibodies are also the presence of human anti-chimeric antibodies. And because of the increased infusion reactions and the anti-chimeric antibody production, there is also newer agents coming up, which are either fully humanized or partially humanized antibodies, so that they do not produce these anti-chimeric antibodies. They are yet to be in clinical use or widespread use. There is also this anti-CD22 drug called the epratuzumab, which is currently being studied in lupus nephritis. There might be some years before it comes to pediatric lupus. B-cell differentiation agents, which are being currently approved in active lupus. There is not much data again in pediatrics, but these agents also work wonderfully well in controlling active lupus. They are not being used in severe lupus as of now, and also not in CNS lupus. So these agents give you, there is the side effect profile includes infusion reactions, there is also infections, and majorly psychiatric disturbances and an increased malignancy load. So we'll have to wait and see what it does for our pediatric lupus patients. Moving on to the complement mediated therapies, I've sort of left off bortezomib here because we do not use it that often in pediatric practice. B-cell targeted therapies also put eculizumab in between because there's a downstream effect of complement inhibition. So this inhibits complement cleavage of complement 5, and it's widely used in the treatment of atypical HUS, transplant-associated TMA, anti-rejection therapies, especially antibody-mediated rejection, and also C3 glomerular nephritis. The main side effect profile of these agents are because failure of opsonization happens because of the action on the membrane attack complex, and encapsulated bacterial infections are high in these patients, especially Streptococcus pneumoniae, Haemophilus influenza, and your meningococcus. Moving on, the other therapy classes include your pooled polyclonal antibodies. The common ones that we use are the Ibm Immunoglobulin and the anti-thymocyte globulin. There's also anti-proliferatives, which are mTOR inhibitors, which act on the cell cycle between G1 and S phase. The antimetabolites called azathioprine and mycophenolate mofetil act on the cell cycle between the S and G2 phase transition. There are also alkylating agents or cytotoxic agents like cyclophosphamide, which have a multitude of effects on almost all cell lines in the body, and they are very, very toxic. And also pan-lymphocyte depleting agents like alemtuzumab. These are not only restricted to your T cells, but they also act on your B cells and all sorts of lymphocytes. So your pooled polyclonal antibodies, one of the most important agents that we use in nephrology is Ibm Immunoglobulin. These are usually used in combination with other therapies, either in context of treatments for vasculitis or antibody-mediated diseases, wherein we use it with plasmapheresis as either a immunomodulator or also as immunoglobulin replacement. They have side effects of anaphylaxis, which is particularly more seen in patients who have IgA deficiency, aseptic meningitis, thrombotic events, and AKI because of the preparations containing sucrose are some of the side effects that we see with these agents. Anti-thymocyte globulin, on the other hand, is predominantly used only in the transplant setting in nephrology. And these agents have the ability to act on primarily T cell, but they also have the ability to attack B cells, monocytes, and neutrophils. And probably in the list of all the immunosuppressants that we discussed, probably this is the most potent and the most devastating immunosuppressant that we have. Because of the shared antigens on all these cells, there are the effects of thymoglobulin does extend to many lymphocytes and many immune-mediated cells. It also has the scary side effect of cytokine release, which is fever, chills, hypotension, pulmonary edema. It can present in any form. It can be very severe and often can result in mechanical ventilation and progress to ARDS. This anti-thymocyte immunoglobulin, thymoglobulin, when given as an induction agent or for treatment of anti-rejection therapies, sort of increases the cumulative immunosuppressive load to the maximum, and these patients are at a higher risk of infections and malignancy throughout their life. Coming to the anti-proliferative therapies, which is the mTOR inhibitors, predominantly sirolimus and everolimus. They have additional to the anti-proliferative effect on the cell cycle, they also have antiviral and anti-tumor effects. So these effects are slightly beneficial, but it's not without other side effects. So these agents have some unique side effects like interstitial lung disease, have a worse metabolic profile here, and also has considerable nephrotoxicity, which manifests in the form of proteinuria and sometimes STMA and tubular toxicity. They also produce this unique side effect of lymphedema. And these agents are either used in the transplant setting. They are sparingly used in glomerular diseases these days, but they are used predominantly in this transplant setting as either CNI minimizing or CNI sparing agents. They are been previously tried in the past for cystic kidney diseases because they do have anti-proliferative properties, and cyst proliferation is decreased when any of these agents are used. They have anti-tumor properties, so they have been tried in various malignancies, including renal malignancies. Moving on to the antimetabolites as a drug group, we have two drugs here which are commonly used in nephrology practice, which is azathioprine and mycophenolate. So these two drugs act on the S to G2 phase transition of the cell cycle, and they are predominantly used in autoimmune and glomerular disease. diseases, and mycophenolate till date is the primary antimetabolite that we use in renal transplant. They share common side effect profile because these are similar to anti-proliferative agents or antimetabolites. They act on your cell cycle, so they're more likely side effects. They affect the cells that are proliferating more, like your hematological cells, your GI tract cells, and also your lymphocytes. So these induce, so their side effect profile is also similar. So they affect your hematological side effects, so you get more of gastrointestinal toxicity, and your infections risk is also higher. Mycophenolate, in addition, has a teratogenic potential. So when you need an antimetabolite in a patient who is planning a pregnancy, we still depend on azathioprine, although azathioprine use as such has come down drastically after the introduction of mycophenolate. The alkylating agent cyclophosphamide is toxic to all cell types. They also have side effects on, they also affect cell groups which are rapidly proliferating, like your hematopoietic cells, gonads, and the bladder. And they also have a considerable risk of malignancy. Cyclophosphamide use is still active in nephrology, especially in autoimmune conditions and secondary glomerular diseases. They're also used in nephrotic syndrome till date. So it's very worthwhile to include drugs in the class of immunosuppressants that we still use. Yes, so moving on. So I discussed in elaborate about the side effect profile of each of these immunosuppressive classes, but I think the more worthwhile exercise would be to group or look at what exactly, because many of these patients do not undergo, get a single drug agent. They are mostly on a multitude of therapies. They have multitude of risk factors. So the infection as a whole depends on the following factors: your net state of immunosuppression, your environmental exposures, and the invasive procedures that the child undergoes. The net state of immunosuppression not only depends on your immunosuppressive therapy, they also depend on your existing barriers, existing defenses to immunity, like leukopenia, impaired integrity of mucocutaneous barriers, metabolic factors like malnutrition, renal failure, hyperglycemia, and proteinuria, either as the process of the disease itself or in response to the drug side effects, can heighten your risk of infections. Infections with immunomodulating viruses like your CMV and EBV can also modify your infection risk. Exposure to environmental factors like endogenous flora. We now have mucor rampant in India because of mucor is always present in the environment, but once your barriers are breached, you have increased infection with these endogenous and exogenous flora. Microorganisms which are acquired in the community. So the more hospitalizations, the more exposure to the community agents, you're going to have more infection risk. The number of invasive procedures and that a child undergoes in the lifetime also increases your risk of infection. The type of organ transplanted. So the infection risk is slightly lesser in renal transplant. It's higher in cardiac and lung transplant. It's also higher in multi-organ transplants. The number of tubes and the number of procedures that you undergo also dictate your infection risk. But cumulatively in nephrology, we have the glomerular disease, which is lower here at the infection risk because of the lower doses of drugs that we receive, that we use for glomerular diseases. The duration of therapy extends to only a few months or at the maximum to a few years. And these children inherently have fewer risk factors. But in autoimmune, the next strata of risk for infection comes with autoimmune disease or vasculitis, wherein we use more intensive chemotherapies for them. Again, the therapy lasts anywhere between few months to few years. The increased non-renal disease burden, like in lupus nephritis, like in children with SLE and other autoimmune conditions, sort of dictates the infection risk in these children. But the higher infection risk is obviously in solid organ transplant, where you receive higher doses, you receive multiple phases of immunosuppression. You again receive immunosuppression when newer agents or multiple agents when you have a rejection. Your lifetime, you receive immunosuppression over the course of life till your end of life. So your lifetime immunosuppression is offered in these children, and these children have a multiple risk factors compared to those with glomerular or autoimmune diseases. This is a very cliche slide which has been used multiple times to denote the infection risk in patients with renal transplant. But I would use this to indicate the infection risk over not only for transplant, but also for glomerular diseases. So the heightened risk of getting infection from any of these immunosuppression, and especially in transplant, is going to be roughly in the first 6 months of your transplant. So the infections initially in the first month is more related to the hospitalization and the surgical procedures that the child undergoes. Can be either donor-derived infections, or children are immunologically and infection naive, so they can get CMV or EBV virus in the from the donor, and this is the period most commonly that they acquire these infections, although their effects can be seen later. Recipient colonization or incubating infections like catheter-associated infections are very after transplant. In the first 6 months of transplant, where probably there's the highest period of immunosuppression that one person could receive, you are at risk of infections due to any of the agents. It could be viral, bacterial, fungal, parasites, or even surgical infections can sometimes overflow into the 6-month period. Over the course of 6 months and beyond, but the important point to note, and in the infection profile, the major difference in our management has come is probably in the 6 months period because of use of prophylactic agents like PCV prophylaxis and also gancyclovir prophylaxis for CMV. After 6 months, we see more of these viral infections because of lack of prophylactic agents or the withdrawal of prophylactic agents in this group, and also the cumulative immunosuppressive load sort of dictates what sort of infections you're going to get in transplant patients beyond 6 months. There are, one should understand about specific infections like CMV. CMV, the lifetime risk of getting CMV depends on your cumulative immunosuppression. The more antimetabolites and more doses of ATG that you receive, you are more at risk of CMV infection. CMV also induces immune paralysis, so CMV sort of puts you at risk of other infections as well. CMV can also increase your risk of post-transplant lymphoproliferative disorder, can cause renal artery stenosis, increase your risk of diabetes and recurrent TMA after transplant. So EBV infection is more common if you have receive a kidney from an EBV positive donor and you're EBV naive. So a younger recipient, a patient who has got CMV disease, who's received ATG, and who is also a recipient of non-renal organ transplant, all of these conditions increase your risk of both EBV infection and post-trauma and lymphoproliferative disorders after transplant. BKV virus infection is again related to your cumulative immunosuppression, but the more older you are, the more aged donor that you get your kidney from, more likely you'll have BKV infection. Also, antigen expression, heightened antigen expression in as it occurs in prolonged cold ischemia time and HLA mismatch can also put you at risk of future BKV infections. Apart from infections, there are a couple of other complications of immunosuppression that I would like to touch upon in detail. So nephrotoxicity is one of the major immunosuppressive complications that we grapple with, and we would completely do away with if we had a choice. So nephrotoxicity is predominantly seen in calcineurin inhibitors. The sad part is that these are still the most promising T-cell agents that we have, and these agents themselves are nephrotoxic, thereby affecting graft function, and therefore in glomerular diseases, it precludes long-term use of these agents. So the risk sort of, you can have both acute nephrotoxicity and also chronic nephrotoxicity. In the acute forms, you have either a transient acute kidney injury because of the vasoconstrictive effects of the afferent arteriolar place, or you can have a TMA-like picture which can produce a rapidly progressing renal failure. But the chronic nephrotoxicity is something that is well recognized as well, and probably the most important. So chronically, because of a persistent decrease in GFR at the afferent, because of the afferent arteriolar constriction and decreased renal blood flow. So this induces certain changes, notwithstanding glomerular sclerosis. It produces tubular toxicity. It also causes eventually fibrosis and FSGS. So there is both glomerular and tubular toxicity with these agents. Certain situations increase your risk of nephrotoxicity with these drugs. So concomitant nephrotoxic drugs, most of our children might be on nephrotoxic drugs like NSAIDs and also receive other immunosuppressants, like sometimes in combination with mTOR inhibitors. It's a bad idea to give those drugs together. Poor hydration and diuretics at any point of time will put them at risk of acute CNI nephrotoxicity, and when continued for a considerable period of time can put them at risk of chronic nephrotoxicity as well. There are certain inhibitors of P-glycoprotein, certain drugs, and genetic polymorphisms. If you're one of these individuals who have a genetic polymorphism, you're more likely to have nephrotoxic side effects. And higher doses and longer duration of drugs will increase your risk of nephrotoxicity. So over the years, in transplant and also in glomerular disease practice, we have realized that keeping a lower targeted drug level is what is needed. And as much as CNI minimization that we could do in our transplant patients as well, has sort of modified the risk of nephrotoxicity for these agents. A few words about the metabolic side effects of all these drugs. Hyperglycemia is one of the widely recognized metabolic side effect. They're mostly seen with agents, corticosteroids, calcineurin inhibitors, and mTOR inhibitors. Bone health, steroids still remain the major agent which influences bone health. Hyperlipidemia is seen again with these corticosteroids, CNIs, and mTOR inhibitors. And multiple agents or in isolation or together can also produce metabolic syndrome. A few words about hyperglycemia. So there are various mechanisms by which hyperglycemia can occur because of immunosuppressive agents. So you can see that you can have either beta cell destruction, decreased insulin secretion, or peripheral increased insulin insensitivity, or increased excessive glucose influx into your bloodstream. So corticosteroids, if you see, can cause all of these effects. So corticosteroids is one of the major factor for producing hyperglycemia, either in glomerular diseases or in transplant setting. Most of the agents that we use are we are never corticosteroid free in glomerular agents. Most of these we still give a small dose of corticosteroids. Calcineurin inhibitors, on the other hand, is used for a lesser duration in glomerular diseases and only in select conditions. But in the context of transplant, the children are on a lifelong CNI therapy. So hyperglycemia is very well described in the terms of transplant. It causes new onset diabetes after transplant, along with corticosteroids. But tacrolimus, between the two agents, tacrolimus and cyclosporin A, tacrolimus is more likely to produce hyperglycemia because of its direct effect on pancreatic islet cells, which expresses the protein FKBP on which the tacrolimus drug acts. mTOR inhibitors also can cause hyperglycemia, but to a lesser extent than the above other two agents described. So malignancy risk is another important side effect that we are all very worried about and would like to decrease the incidence of. With these agents, the malignancy risk is predominantly seen with post-renal transplant situations, and also sometimes with alkylating agents, which we use in glomerular disease. These agents various agents can act at various levels and can cause DNA mutational damage, or they can interfere with mechanisms of DNA repair. They can also inhibit apoptosis and also interfere with vasculogenic or angiogenic factors, resulting in metastasis and neoplasm formation. Probably the most important cancers that we know of are, in terms of numbers, the skin cancers are the highest, have the highest incidence. And but this is the post-transplant lymphoproliferative disorder is something that we are more bothered and worried in children because they are EBV naive and are more likely to have these disorders. Moving on to other complications, complications of bone and growth, corticosteroids still remains the major factor that influences bone health. There is accelerated growth in the initial 3 to 6 months, but followed by sustained low bone formation, and the risk, as I said, is even seen at chronically low doses. Reproductive health is another important side effect seen, which should be looked for in children, and the causes for poor reproductive health is multifactorial. It could be either because of metabolic syndrome, malnutrition, teratogenicity of some of these drugs that we use, and also gonadal toxicity can hamper your ability to reproduce. Gastritis, colitis and enteritis can all be seen either in the context of steroids or with antimetabolite agents which acts on GI tract cells. Neurotoxicities of some of these agents, the most important of which are your steroids and calcineurin inhibitors, include psychosis, seizures, PRES, and also cataracts that can be seen with steroids. Cardiovascular risk factors like hypertension and other total cardiovascular morbidity are also increased with a multitude of these agents. When you look at the data that is available over the last few years on how much of the side effect or the adverse effect profile of our drugs. So this is one of the excellent systemic analysis that we have for children with nephrotic syndrome. The highlight of the study is they have looked at least a 10-year follow-up of children who have developed nephrotic syndrome as children, and they followed up them either till adolescents or young adults. If you see, there is a considerable, and the agents most commonly used are steroids, azathioprine, and calcineurin inhibitors. Mycophenolate, rituximab are probably not part of these studies because they are predated. So when you see, there is a considerable risk of growth impairment, anywhere between 6 to 20%, and the growth retardation is more when you have patients who have multiple relapses even going into adulthood. Obesity, osteoporosis, and fracture risks are also very high, even with the immunosuppression corticosteroids, azathioprine, and calcineurin inhibitors. So this also tells, it's not specific to a single agent. It tells the important risk factor of the interplay of disease and multiple drug agents used in nephrotic syndrome. The same study also tells the risk of cataract and hypertensive retinopathy, which is sometimes very high in patients who have multiple relapses. So steroids are the main agents causing these drugs, causing these complications. Again, hypertension can be anywhere between even 33% in steroid-sensitive nephrotic syndrome children. So the hypertension risk is very high, even in children who have relatively better controlled nephrotic syndrome. Hyperglycemia risk otherwise is not well documented in glomerular diseases, except for this one study which highlighted the incidence of impaired glucose tolerance to almost 14%. There's also, I would, for the interest of time, I would ask you to refer to this paper for more information on nephrotic syndrome. I'm missing a couple of slides here. I'm not sure what happened, but let me tell you. But also the data on immunosuppressive therapy and side effect profile for autoimmune diseases and also transplant have sort of become better over the years with lesser use of steroids, with more CNI minimization and better risk profile modification and screening tools that we have. So moving on to the monitoring and screening tools that we have, this could be taken into context of both transplant and glomerular diseases. The most important of it is the clinical risk assessment prior to starting of therapy that all of us should do. The risk assessment should include assessment for infections, like mostly viral infections, but not limited to syphilis, tuberculosis, and other viral infections like hepatitis B, HIV, CMV, and EBV. You can do serological testing for these agents. Imaging can be used and cultures can be used. Metabolic monitoring is also important to either during or prior to initiation or after every change or increase in immunosuppression or as routine monitoring. Hematological monitoring and immunological monitoring, especially in the context of transplant. So when you have an increased risk of DSAs, you increase your immunosuppression, whereas if it's well controlled, you can sort of come down on your immunosuppression. These are some of the screening tools that's given in this slide. I'm going to not touch upon in detail about this. Also, the next, after monitoring and screening strategies, the next predominantly useful strategies for reducing our immunosuppressive complications are going to be prophylaxis and vaccinations. So currently we use prophylaxis for PCP for pneumocystis jirovecii pneumonia. We use it for CMV. And we also use it sparingly for varicella infections and for fungal infections in glomerular diseases and in transplant. Moving on to infection prevention, vaccinations still form the main crux of main tool in our hand to prevent infections, especially in children. So So prior to initiating immunosuppression or solid organ transplant, it is very important that you ensure that your child is optimally vaccinated. Also offer additional vaccines in children undergoing transplant like hepatitis A, pneumococcal vaccine, varicella, and annual influenza vaccine. I'll show you the catch-up and accelerated schedule if you fail to vaccinate these children before transplant. Inactivated vaccines must be completed at least 2 weeks prior so that they have an adequate immune response, and live vaccines not later than 4 weeks before organ transplant to prevent vaccine-induced infection. Also, very important that you vaccinate household and close contacts of these children. So this is the accelerated schedule given here. You can there's an excellent review article. You can go back to it and see. So if you have a solid organ transplant child who is not not vaccinated before transplant, these schedules can be used. Also, once you are potentially immunosuppressed, your risk of infection is high, and you've already contracted your infection or you have exposed to an infection. This is again the schedule for immunoglobulin administration and certain prophylaxis that you can use to decrease your infection severity or prevent from getting an infection. And this is also the criteria for live vaccination in a child with solid organ transplant. I will not go into the details of this due to the interest of time. So this brings me to the last slide. Managing immunosuppression and managing the complication risk is not easy in children. You should understand the complex effects of the multiple immunosuppressive agents that are there. Also understand the interplay of drugs and the disease. Children have unique needs and developmental effects. Your focus should be more on surveillance rather than treatment. Reducing cumulative immunosuppression once disease control should always be done. Use appropriate monitoring and all available tools. Vaccinations and prophylaxis still remain the main tool to prevent infection, and newer agents are likely to bring new challenges. Thank you.
Thank you, Dr. Sukanya, for taking us an extensive class on immunosuppression and its complications in nephrology. And the next speaker for the day is Dr. Abjet Shah. Dr. Abjet Saha is a ISPN IPNA fellow from AIIMS, and he is a professor of pediatrics, division of pediatric nephrology at Lady Hadrange Medical College and Kalavati Saran Children's Hospital, New Delhi. His academic interest is towards endothelial dysfunction in nephrotic syndrome, proteomics and metabolics in kidney disease, AKI and CKD. And he has also received a best research paper in ISPN Con for the year 2012 and 2016. He has got more than 100 publications to add on, and he is a current editor-in-chief for ISPN Bulletin. Over to Dr. Abjet Shah to deliver his talk on pathophysiology of immune system and its impact on glomerular injury.
Thanks, Dr. Kalaivani, for the excellent introduction. I am audible and my slides are visible?
Yes, sir, you're audible, sir. Your slides are visible as well.
Thank you so much. So at the outset, I thank Professor Namalwar and Dr. Kalaivani for organizing this series of excellent lectures, and also inviting me for this very interesting talk on pathophysiology of complement systems and its impact on glomerular injury. So to begin with, in 1895, Dr. Jules Baudet from Belgium first gave a hint about complement when he was working through many of his immune-related experiments, and this experiment was with live vibrios. And later on, the complement system was identified and was initially called as Alexin from the Greek word to defend, but the name complement was later coined to describe the role of this system in complementing the function of antibodies. In the year 1919, Professor Baudet was awarded Nobel Prize in Physiology for his excellent experiments in the field related to immunology and in particular complement system. And today we know the importance of complement system. So it's an important part of immune system that helps protect the host from infection. And it is activated by immunoglobulins and immune complexes, but activation can also be triggered by several other molecular patterns and proteins. Now, uncontrolled or inappropriate complement activation causes inflammation and has been implicated in the pathogenesis of a wide range of kidney diseases, which we'll see today. Now, the therapeutic complement inhibitors have been approved for the treatment of atypical hemolytic uremic syndrome, and may also be effective in many other kidney diseases, as a lot of newer molecules are being evaluated in different clinical kidney diseases. To begin with, just for the fellows or postgraduates, just a recap of the complement system. So we know that the complement pathways are three: the classical pathway, the lectin pathway, and the alternative pathway. Now, the classical pathway is triggered by or activated by immunoglobulins and many other proteins when they bind to the ligand, and after binding with the ligand, they engage C1q, and then later on formation of C1q RNS leads to cleavage of C4 and C2, leading to formation of the C3 convertase of the classical pathway, namely the C4b2A. Now, the C4b2A cleaves the C3 into anaphylotoxins, the C3b and C3A. Similarly, the lectin pathway is activated by mannose binding lectin, some ficolins and collectins when they bind with the sugar. And after binding with the sugars, they engage with the mannose associated serine proteases. And again, this leads to cleavage of C4 and C2 and formation of the C3 convertase of the lectin pathway, which again cleaves C3 into anaphylotoxin C3b and C3a. Now, the alternative pathway is a little different. It is spontaneously activated and with the process called as takeover, when C3 combines with water and leads to an ester bond formation, and which ultimately leads to again cleavage of C3, formation of C3b, to which combines the factor B, and the factor D then cleaves factor B, leading to formation of the C3 convertase of the alternative pathway, the C3bb, and which leads to again formation of an C3b, which has got an amplification loop. So this is in nutshell the three pathways, and we will see further how they act and what is the importance in glomerular injury. Now, alternative pathway mentions need special mention because they are spontaneously and indiscriminately activated, and they deposit a low level of C3b on nearby surfaces. It self-amplifies on surfaces unless they are inhibited by regulatory proteins, and the activation after it is initiated, it amplifies the activation after it is initiated through the classical pathway and the lectin pathway. And the alternative pathway activation does not require any specific recognition events that trigger the classical pathway or lectin pathway. And that is why proper regulation of alternative pathway is even more important than the other two pathways, the classical and the lectin. And therefore, genetic mutations in complement regulatory proteins are commonly associated with dysregulation of the alternative pathway. And that is why we see so many diseases which are now we know that apart from other pathophysiology, they are related to alternative pathway as well. Now, all these combine to the terminal pathway, where here you can see the C3 convertase combine again with C3b and lead to formation of C5 convertase. So this is the C5 convertase of the alternative pathway, and this is the C5 convertase, the C4b2A3b. B is the C5 convertase of the classical and the lectin pathway. They cleave C5 into C5a and C5b, and then it leads to formation, further association with C6, 7, 8, 9. It leads to formation of the membrane attack complex, which leads to activation of many neutrophil and many other intermediate chemoattractants, which leads to damage of the membrane. Now, inhibition of C3 convertases is crucial to maintain the milieu and the balance, and this is done by two processes. First is the decay acceleration, wherein decay accelerating factor DAF or factor H, they cleave the C3 convertases irreversibly, the BB and into C3b, and also a process where factor I mediated cleavage occurs, where factor I converts C3b into inactivated C3b and also to factor C4b into inactivated C4b. Now they all require, the factor I requires not only factor H but also CD46, the membrane cofactor protein, the CR1, that is complement receptor 1, and C4BBP. So this is about the inhibition of the C3 convertase. Now we come to the disease, different diseases. So thrombotic microangiopathy is thrombocytopenia, microangiopathic hemolytic anemia, which leads to end organ damage. And we know that acute kidney injury is one of the centerpiece of hemolytic uremic syndrome. And here on the panel, you can see a biopsy of hemolytic uremic syndrome, where the glomeruli are enlarged, edematous, congested, and the blue arrow downwards here you can see there is a collapse of the, because of the edema, there is a collapse of the subendothelial spaces, and the upper here you can see some early formation of microthrombi as well. Now, this slide shows that there are different genetic mutations which are related to atypical HUS, and good number of them are related to alternative pathway activation, or you can say unregulated action of the alternative pathway. Now these mutations can be in the complement genes, some of them can be in non-complement genes, and some of them can be also because of the acquired abnormalities. And to name with mutations in the C3, complement factor B, complement factor H, I, thrombomodulin gene, complement factor H autoantibodies, complement factor H related proteins 1 to 3 deletions, the MCP mutation, the membrane cofactor protein mutations, the plasminogen mutations, and the NF2 mutations. Now all these can lead to lead to atypical hemolytic uremic syndrome. And the C3b and C5a, you know, causes anaphylaxis, inflammation, thrombosis, later on formation of the membrane attack complex, which leads to proteinases and free radical injury, leading to thrombus formation and activated platelets, which further leads to the thrombotic microangiopathy. Now, the genetic mutations which are seen in patients with atypical HUS can be because of gain of function, or for example, the C3 and the complement factor B, or can be because of the inactivating mutation, the loss of function mutation. So complement factor H, complement factor related protein FHR3, the membrane cofactor protein, the complement factor I, they are all inactivating mutation. And here you can see the complement factor B, it leads to ESRD in almost 70% of patients. So this is about the genetic mutations in atypical HUS. Now, there is a role of complement activation in STEC HUS as well. And though recently studies have shown that in STEC HUS as well, there is activation of the complement system. And also, there are some case reports where in certain cases, different drugs to suppress the complement system has resulted in benefit in STEC-HUS as well. So here what happens that the toxin, the Shiga toxin, it binds to the GB3 protein on the membrane and is immediately internalized here. And here you can see it again gets internalized inside the Golgi apparatus, from where it is released in the cytoplasm. It binds to the ribosomes and then leads to activation of the caspase, which is a apoptotic pathway that it invites a lot of neutrophils, macrophages, and leads to ultimately endothelial dysfunction and leads to thrombus formation. Now, the evidence of complement activation in STEC-HUS is seen with the increased plasma level of C3 convertases, C3b, complement factor B, C3c, C3d, and also to the fact that the Shiga toxin is able to attach with the complement factor H and leads to dysfunction of the complements on the surfaces. And the evidence of involvement of the terminal complement cascade and the membrane attack complex is also evidence with the increased level of the membrane attack complex, and also to the fact that the CD59 mRNA, which inactivates the TCC, is suppressed, and also that the P-selectin expression is increased, and this P-selectin it engages or captures C3, which leads to again complement activation and also attraction of for the RBCs, endothelial dysfunction, fibrin rich thrombus formation, and fragmented RBCs. So this is about the role of complement in STEC-HUS. Now, we also know that based on these studies, eculizumab, which was initially in 1987 was being evaluated for PNH, and later on was used in many autoimmune diseases, and Solaris was given the approval by the EU Commission for the use in different autoimmune disorders in the year 2007, and finally with studies coming up in 2011, eculizumab was given FDA approval for the use in atypical HUS as well. And we know that it is a humanized monoclonal antibody which blocks the cleavage of C5, so that the C5a and C5b is not formed, and that is why the membrane attack complex is also not formed. So we all know that C5a is a potent anaphylatoxin, is a potent chemoattractant and causes cell activation. So this process is halted, and that is how eculizumab acts in atypical HUS and is being evaluated in many more kidney diseases. And this is the ISBN recommendation for the management of hemolytic uremic syndrome for developing countries, including India. And here you can see that eculizumab, though it's currently not available with us, but if available, should be considered in patients with atypical HUS, even in developing countries. Now coming to an interesting disease, which was previously called as membranoproliferative glomerulonephritis, and was classified into MPGN type 1, type 2, type 3. Type 2 was known as dense deposit disease. And here you can see a capillary loop and the electron microscopic picture of the three types. And I don't know whether you can see the pointer or not. Here, this is the capillary loop. So this is the subendothelial deposits here, the glomerular basement membrane, and this is the subepithelial layer. And in dense deposit disease, you can see the intramembranous deposits here, highly osmophilic intramembranous deposits, and the type 3 where there is both subendothelial and subepithelial deposits. Here you can see three arrows, three red arrows. These are the subepithelial deposits, the intramembranous linear deposit here, and also the 5 arrows, 1, 2, 3, 4, 5. These are the subendothelial deposits. Now later on, with new papers coming up from Dr. Sethi and many other groups, and they found that they reclassified the MPGN into C3 glomerulopathy, which today we call as a C3 glomerulopathy, and divided MPGN primarily into two groups: the MPGN immune complex mediated, which is you find a lot of immune complexes, and it is not dominant for C3, but there are a lot of immune complexes, and they occur primarily because of infections, autoimmune disorders, and because of monoclonal gammopathies or dysproteinemia. And the other one known as C3 glomerulopathies, the C3G we call it as, where there are no or very few immunoglobulin complexes, and it is C3 dominant. And what is meant by C3 dominant is that the C3 is more than 2-factor dominant as compared to the other immune reactants. And the C3 glomerulopathies, based on the electron microscopic picture, is divided into C3 glomerulonephritis, the C3GN, and the dense deposit disease based on the electron microscopy. And here you can see on the panel a child, one of our patients with dense deposit disease. And on light microscopy, you can see lobular accentuation, increase in the blue arrow shows the increase in the mesangial matrix, and a lot of polymorphs as well. And here the C3, the immunofluorescence C3 panel, the yellow arrow shows C3 deposits in the mesangium, and the white one shows a peripheral capillary wall deposition of C3. And this is the electron microscopic picture. And here you can see, again, I'm not sure if you can see the pointer. This is the subepithelial layer, the glomerular basement membrane, which is thickened, and the classical ribbon-like deposits inside the membrane, which is characteristic of the dense deposit disease. And this one, the next one is C3 glomerulonephritis, and here you can see two blue arrows, and this is the classical splitting of the glomerular basement membrane, and interspersed is the endothelial cell, and the white arrow shows the intramembranous deposit in a child with C3 glomerulonephritis. Now coming to the antibodies which activate the complements and immune complex MPGN and C3 glomerulopathy. Now there are different antibodies, like the most widely studied is C3 nephritic factor, the others being C5 nephritic factor, C4 nephritic factor, anti-factor B, C3b complex, and also anti-factor H. Now these antibodies, they have different target neoepitopes on the alternative pathway and also on the classical and the lectin pathways, and these antibodies actually stabilize the C3 convertases, and they prevent the spontaneous decay, and they actually increase the half-life from minutes to even hours, leading to again activation of the complement cascade and leading to the glomerular injury. Now, this is about the complement regulation by the factor H. Now, the factor H has got around 20 SCRs, what is known as short consensus repeats, and it has got two terminals, the N terminal and the C terminal. Now, the complement regulation by the first four SCRs, 1 to 4, they are responsible for the decay accelerating activity and the cofactor activity, and in the fluid phase, abnormality in these SCRs is responsible for the C3 glomerulopathy. And the C terminal, the 19-20 SCRs, they are responsible for the impaired ability of factor H to control the complement activation on the surface on the solid phase, and they lead to most of the mutations of the factor H, which result in atypical HUS, are situated here on the SCR 1920. So this is how, because of abnormality of the complement factor, single complement factor, you get a two spectrum of a disease probably. Now, this is about the therapy, and there is a Eagle trial recently published 2019 AJKT, where 10 patients with C3 glomerulopathy were followed over 2 years. They were refractory to other therapies and were evaluated with eculizumab and whether it acts or not. Though eculizumab blunted the terminal complement activation in all patients with immune complex mediated MPGN or C3 glomerular nephritis and nephrotic syndrome, but persistent reduction of proteinuria is seen on only a subgroup, to be precise, in 3 patients only. So there is still scope of a lot of research and new molecules in the management of C3 glomerulopathy. And new complement inhibitors targeting early complements of the complement cascade, namely factor D or factor B, are being evaluated currently in C3 glomerulopathy. Coming to complement and immune-mediated glomerulonephritis, so this cartoon shows that the immune complex formation can be because of 3 processes. First, the antigen over here, it gets deposited here, attracts immunoglobulin and leads to formation of the panel 1, number 1, leads to formation of an immune complex in the GBM. Or there is a possibility that preformed immune complexes in circulation can be trapped in the glomerular basement membrane and they lead to formation of immune complex. Or thirdly, the endogenous antigens of the glomerular basement membrane, they can attract immunoglobulins and lead to formation of immune complexes. Now, depending upon on the panel B, you can see the subendothelial immune complex formation, the glomerular basement membrane immune complexes, and the subepithelial immune complexes. The location of immune complexes affect the histology and the clinical patterns of injury. Coming to lupus nephritis. Now, this cartoon shows that the immune complexes in lupus nephritis, they activate the classical pathway and alternative pathway, and because of these activation, the different complement proteins, they get deposited over the immune complexes, and it is the C3b which does the opsonization of these immune complexes and brings these immune complexes through the RBCs, which requires complement receptor 1 to the liver and spleen, and there occurs the damage. And also that the C5a, it causes activation of C5aR, which again leads to organ damage. Now, in lupus nephritis, genetic deficiency of several components of the classical pathway, including C1q, C1r, C1s, C4, and C2 are associated with development of SLE. And deficiency of C1q has received much attention and strongly predisposes individuals to SLE development. And it is thought that it is related to the role of C1q in the removal of the apoptotic cells. And also that apoptotic cells have lupus anticoagulant on the surface, and in the absence of C1q, these cells are not efficiently removed, which is thought to stimulate an inappropriate immune response to the autoantigens. Coming to the histopathology, now the glomerular co-localization of IgM, IgG, IgA, C1q, C4, and C3 is the classical feature of lupus nephritis, what is known as the full house pattern. And also in biopsy, you can get C5b9 staining, and in presence of alternative pathway activation, factor B can also be seen in the biopsies. Now, this is a panel which shows again on low power a large glomeruli with lobular accentuation, prominent endocapillary proliferation, and lot of polymorphic infiltration. On the other panel here, on the black arrow shows again the mesangial matrix expansion and also a lot of polymorph nucleus cells, and the white one shows the wire loop appearance, which is again seen in lupus nephritis. Now, what is full house pattern? Now, here you can see IgG both in this panel, both in the mesangium and also in the glomerular capillary peripheral capillary wall. And if you look at the C1q, very interestingly, apart from the peripheral capillary wall, you can see over the Bowman's capsule is also light up. So this is again C1q deposition in the Bowman's capsule. And if you can look at where the white B is written above that, you can see the tubules. Now these tubules are also light up. So these are deposition of C1q, and this is all what is known as the full house appearance in lupus nephritis. And again, IgG, you can see the upper blue arrow shows a peripheral capillary wall deposition of IgG, and the lower one you can see inside the nucleus what is known as the inside the nucleus also what is known as the ANA effect of lupus nephritis. Coming to this EM panel, which on low magnification, here you can see the white arrow shows a full capillary loop. You can see the subepithelial surface, the glomerular basement membrane, and the subendothelial surface as well. And here you can see the epithelial surface, the glomerular basement membrane, and also the subendothelial space. And here the blue arrow is an endothelial cell, and in the cytoplasm you can see a mesh-like structure, and this is again classical of lupus nephritis, the tubulo-reticular pattern which is seen in lupus nephritis. The mesh-like pattern with the blue arrow is classical of lupus nephritis. Again, the blue panel, the blue arrow, it shows the dense subendothelial deposits. Here you can see above the blue arrow, the podocytes here, the subepithelial layer, the glomerular basement membrane, the subendothelial layer, and the large subendothelial deposits in lupus nephritis. So coming to the therapy, so there are a whole lot of new therapies coming up, both in SLE. Some are already established and others are coming up because of new discoveries in the pathophysiology of SLE and lupus nephritis. And apart from rituximab, which is now well established, the anti-CD20, there are other monoclonal antibodies, and also here you can see infliximab, eculizumab, and certain other therapies being used for lupus nephritis. Coming to IgA nephropathy, so it's a common cause of glomerular nephritis, and up to 40% of the cases progress to ESRD over 20 years. Now, the pathogenesis of IgA nephropathy is multi-pronged. It can be described in 4 steps probably. So first of all, there is an increased level of galactose deficient IgA1, which leads to formation of IgG antibodies. So this is step 2. The step 3, there is a formation of immune complex of these galactose deficient IgA1 and the antibodies leads to immune complex formation. These immune complexes, they reach the kidneys, they get deposited, cause mesangial proliferation and inflammation, and lead to complement activation here. And on the other side, you can see that there is an activation of the lectin pathway, the alternative pathway, and also the terminal pathway proteins. So in stable IgA and progressive IgA, the level of different intermediates molecules, they differ. So ultimately, in progressive IgA, there are certain molecules of complement, both in the lectin or the alternative pathway, and also the terminal pathway protein C5a and C5b9, which leads to, again, activation of the different pathways, chemoattractants, and ultimately leads to injury to the glomerulus and the podocytes. And this is again on light microscopy. Here you can see increased mesangial matrix. Lot of the blue arrow shows increase in the mesangial matrix, lot of polymorphonuclear cells. And below panel, you can see the classical mesangial deposition of IgA. And the evidence of activation of different pathways comes with the evidence of deposition of C3, properdine, C5b9, C1q, the mannose binding lectin, picoline B, and other intermediates. Now, and because of these discoveries, here you can see, apart from other therapies in Ig nephropathy, various complement inhibitors are also being studied, namely avacopan, the C5a receptor blocker, the complement factor B inhibitor, LNP023, and the mannose binding lectin associated serine proteases, the MASP2 inhibitor, the OMS721. So these are all being studied now. And lastly, coming to the membranous nephropathy. So again, it causes nephrotic syndrome and characterized by immune complex deposits in the subepithelial space of the glomerular capillary wall. Approximately 40% can lead to ESRD over a period of 5 to 10 years. Now, around 25% of them are known as secondary membranous nephropathy, and it might be because of infections, medications, neoplasias. While primary membranous nephropathy is a kidney-specific autoimmune disease, which is induced by autoantibodies that recognize protein expressed on the surface of the podocytes. And with a landmark study of Lawrence Beck et al., it was seen that M-type phospholipase A2 receptor, the PLA2R, are the main podocyte target antigen for autoantibodies in the primary membranous nephropathy. Now, in membranous nephropathy, as you can see on this side of panel, the antigens can be endogenous antigens, which are on the glomerulus, namely the PLA2R, and the other one is the anti-thrombospondin type 1 domain containing protein 7A and certain others. Or there can be some exogenous antigens like cationic bovine specific antigen. Now, both these antigens, they activate the complement system, and there can be also a direct effector roles of these antibodies, which leads to inhibition of, which can lead to inhibition of the enzymatic activity, the receptor function, the protein-protein interaction, the podocyte adhesion, and also in the alteration of the signal transduction. Coupled with the activation of the complement pathways, there is ultimately a podocyte damage. Now, the anti-PLA2R antibodies are highly specific for primary membranous glomerulopathy and are not found in other forms of glomerular nephritis or in secondary membranous glomerulopathy. And here you can see the classical fine granular deposits on the peripheral capillary wall, which is again classical of membranous nephropathy. And this is the electron microscopic picture. There are two panels. The first one shows the subepithelial electron dense deposits, and the panel B shows the subepithelial electron dense deposits, and also the membrane spikes, which are seen in membranous nephropathy. Again, an intramembranous deposit, which is seen with the arrow. Here you can see this is an intramembranous deposit in membranous nephropathy. Now, this is a panel which shows we had some time back around 5 patients of idiopathic membranous nephropathy, and we evaluated these for the PLA2R antibodies. And here you can see the patient number 2 panel, Western blot analysis shows the reactivity with the native PLA2R band, the indicating presence of anti-PLA2R antibody in case 2. And further on, this next panel shows you IgG1 class antibody, while other bands are not light up, little bit of IgG3 and IgG4, whereas the last panel shows you the bovine specific antibody, which was not seen in any of the patients. So this was, the patient 2 was youngest. I mean, he was 10 years old and he did show a anti-PLA2R activity. So what is the evidence? So in the kidney biopsy, you can get stains of IgG1, IgG4, even C1q, mannose binding lectin, complement factor HB. These all can be stained in the kidney biopsy. And again, newer drugs which are being evaluated, the monoclonal antibodies in Ig nephropathy, in membranous nephropathy. And again, one of our patients, the latest one who was diagnosed with membranous nephropathy, here you can see the markedly thickened glomerular basement membrane. The upper one here, you can see the subepithelial layer, then the glomerular basement membrane, which is markedly thick, and lower down you can see the subendothelial space. So to summarize, a whole lot of new complement drugs are being evaluated in different kidney diseases, apart from eculizumab, so many difficult to pronunciate these newer drugs, but a whole lot of drugs being evaluated for different disorders. And maybe in future, we will get more of such drugs through which we can treat our patients better. I have not touched upon 2 more diseases where there is evidence that there is an activation of the alternative pathway, the anti-neutrophilic antibody associated vasculitis, where again avacopan is being evaluated, and also post-infectious glomerular nephritis due to, in the interest of time. So to conclude, there is a emerging evidence of implication of complement dysregulation in a wide range of kidney diseases, potentially identifying new therapeutic areas. Measurement of serum C3, C4 levels provide important diagnostic information in the assessment of patients with kidney diseases, and eculizumab is already in use in hemolytic uremic syndrome. And my acknowledgement is due to Dr. Vinita Batra, Director Professor, Division of Nephropathology, Department of Pathology, G.V. Pant Institute of Medical Sciences and Research, New Delhi, for helping us in doing biopsy and even electron microscopy free of cost for a poor patient. And she has been helping us for over 15 years now. Thank you so much.
Thank you so much, sir. It was a very good session. Thank you so much. We just have one question. I think the question is directed towards Dr. Sukanya. Dr. Sukanya, you're there?
Yeah, I'm there.
Yeah. Can you predict or measure the immune balance, that is the degree of immunosuppression?
Yes. So we currently do use whatever is available to us to predict the degree of immunosuppression, be it therapeutic drug monitoring, or we use CD3 levels, or we use CD20 levels. And we sort of use cell counts and other markers for infection, like your PCR, to assess your degree of immunosuppression and also the risk of infection. So I think this tool is mainly to assess the immune responses needed, mostly in renal transplant, where you're balancing the risk of rejection versus infection. In the recent years, there's been some assays which sort of predict T cell function based on their energy expenditure of the T cells. They can sort of differentiate between infection versus rejection. They sort of, I think, use ATP. It's a cell assay called the Immuno. But there's been conflicting results with those, and there's some overlap between infection and rejection. There are also some set of tests or certain tests which use multiple cytokine signatures, which can predict what sort of, so you have a rejection-based cytokine profile, you have a infection-based cytokine profile. So these things probably will come in the future where we are moving towards precision medicine. We are moving towards individualized medicine. It's still very early days to say that these things work very well, but I think the future is towards them. But currently, we do only these levels of monitoring which are available to us, like therapeutic drug monitoring and certain food tests that I said before. So that is what we currently use, but future is going to be probably different. We are going to use either these cytokine-based assays or T-cell functional assays.
Okay, fine. There is a question in an email. What is the role of angiopoietin-like 4 protein in immune-mediated glomerular injury? Dr. Abjet Sir, or like anyone can answer the question.
Angiopoietin-like, it is still not come in clinical practice, I think. It has been used as a biomarker in nephrotic syndrome. I know of one study from CMC Vellore by Dr. Suresh M. I think it was presented from India. Also, there are papers, but it has not come into clinical use as well. Yes, it is one of the markers being evaluated in glomerular nephritis and in nephrotic syndrome as well. That is what I am aware of as of now.
Okay. Like 4-5 years back, like Supar was very leading, like there was extravagant use of Supar. Are we still using Supar as a marker extensively?
I don't think so that it has gained a lot of, I think there was a paper from All India Institute where it was increased in CKD as well. So I am not sure whether Supar has gained a lot of popularity after that. I'm not aware.
Okay. Thank you so much, sir. Just one question to Dr. Sukanya. Like prior to giving rituximab, there are many centers who do immunoglobulin profile. Like, are we right in, are we not, we are not doing it in our center, but should we start doing immunoglobulin profile prior to dosing with rituximab?
I think the center-based policies also differ based on how much you're using, the volume of cases, the type of patients that you're using rituximab for. And I would definitely recommend immunoglobulin level checking if you have already encountered infection in a patient or a patient who's already had a lot of infections in the past, either with rituximab or other immunosuppressive agents. I'd definitely recommend doing that. I think that's the good goal. Immunoglobulin levels for everybody who's going to receive rituximab is something still controversial. And but we should definitely do immunoglobulin levels if they are at a higher risk or have had infections. That's what I would do. That's what I think we should be doing.
Okay, fine. Thank you so much, sir. Thank you, Dr. Sukanya. Thank you, Dr. Menaka. Like we are done with the questions as well. Like it was really an interesting and excellent session by all three of you. Thank you so much.
Thanks a lot, Dr. Kalevani, and thanks Dr. Menka and Dr. Sukanya for their presentations. Thank you.
Thank you.
Thank you, sir.